Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss-Studientelegramms. Marcus at Home welcomes Dr. Emma Svennberg in Stockholm, Sweden, with whom we would like to discuss screening for atrial fibrillation in primary prevention, focusing upon her STROKESTOP trial that has been presented as a late breaker at the last ESC meeting and published just some weeks ago in Lancet. Emma, thanks a lot for taking the time for being our guest tonight.
Thank you very much for having me. I'm looking forward to tonight's discussion.
So Dr. Svennberg is a cardiologist at Karolinska Institute in Stockholm, Sweden, and her major research interests are atrial fibrillation, and she's the chair of the EHRA Digital Committee of the European Heart Rhythm Association. My co-moderators tonight are both cardiologists, Stephan Schirmer in Kaiserslautern, Germany, Florian Custodis in Saarbrücken, Germany. My name is Gunnar Heine in Frankfurt, Germany. I'm a nephrologist.
At the past ESC Congress, we've seen two milestone studies really on stroke detection in otherwise asymptomatic and healthy individuals at rather high risk of stroke because of their age. So people with no atrial fibrillation in the past. Today we'll be discussing the STROKESTOP study with Emma Svennberg, who has done a very pragmatic study in Sweden using a population of 75 and 76-year-old people from two regions in the country, provided half of those agreeing to participate with an external event recorder, a thumb ECG, and people were instructed to record 2 ECGs every day for a period of only 14 days. And they compared that, the authors compared that to a control groups. And so there were more than 14,000 people in each arm of the study. And the basic finding was that using this thumb ECG, one could actually find high rates of paroxysmal and hitherto unknown atrial fibrillation and prevent strokes and systemic embolism and mortality by that, which was the primary endpoint. And very interestingly, at a similar time point, we've seen a Danish study, the Loop study, where the authors tried a little bit of different approach, implanting a loop recorder for continuous ECG monitoring and look at atrial fibrillation in that recorder. And astonishingly, at least using the primary endpoint, again, reduction of stroke and systemic embolism, using this implantable loop recorder in the Loop study, the primary endpoint was not met, although the number of strokes and systemic emboli was actually reduced nominally. So the interesting issue now is, do we see, or what is the best method to use for atrial fibrillation detection to prevent strokes?
Yeah, Emma, great to have you here tonight. Let me just start with a little bit of background. Since Crystal AF, we know that a large proportion of patients with cryptogenic stroke have atrial fibrillation. And not being an expert, one might think, well, screening for AF automatically will change prognosis because everybody diagnosed with AFib will be treated with anticoagulants. But instead, for years, the opposite was the truth. We did not really know if screening would do everything for prognosis. And last year, your data of your study really changed that field of knowledge. But before we get to the data, maybe you could just introduce us and tell us a little bit about the rationale of the STROKESTOP study first.
Well, indeed, the STROKESTOP study is a very pragmatic population-based screening study in which we really tried to mimic how screening would take place if it was performed in Sweden today. So what we really wanted was a very simple inclusion criteria, and in STROKESTOP we just used the age of 75 or 76 for inclusion. We actually had no exclusion criteria, as that is how a population screening would normally be set up. And we also wanted to look at hard clinical outcomes, because we did know already that if we screen for atrial fibrillation, we will likely detect more atrial fibrillation. But would we be able to initiate treatment, and would we be able to look at hard clinical outcomes? That was really our main interest. So could we affect the prognosis of patients with newly screen detected atrial fibrillation?
And so you started with one special point, and I'm wondering, this pragmatic approach for screening solely based on age. Could you just introduce us, what is the background for that? One might think that CHAS-VASc score based or risk factor based screening would be optimal, but you choose another totally other way. What was the rationale for that?
Well, the rationale was, of course, if you're 75 or 76 years old, you already have 2 CHAS-VASc points, regardless of your gender, even if you don't have any other risk factors. So you would be eligible for oral anticoagulants in case you detected atrial fibrillation. So that was one of the rationales for choosing age. And the second one was that it was very simple. So you didn't have to do any pre-screening, no other tests. So you could just start to include at that age.
Thank you for having you here. This is a great opportunity for us. I'm also very, very curious, and obviously Florian alluded to it already. The speciality about STROKESTOP, in our view, is really the simple way of a pragmatic approach, as you described it, and obviously also the positive finding. And I think the sort of elephant in the room here is that we have a simultaneously published study, as you very much know, and probably have been discussing all over the place, the LOOP study, which did not find a positive outcome. Why don't we start discussing that? I mean, what I find interesting in STROKESTOP, you have actually nominally very mild reduction in the endpoint, but yet a significant one. Is it all about the fact that using this pragmatic approach, we only find longer periods of AF, and that maybe these couple of minutes of AF is not clinically meaningful?
I think that is a great point, actually. In STROKESTOP, what we did was that we did intermittent ECG recordings, so just 30 seconds for 14 days. So that's a grand total of 7 minutes or 14 minutes, sorry, of ECG recordings. So it's a very short amount of time, really. And if you compare that to the LOOP study, that's a continuous recording for 3.3 years on average in their study. Of course, there's a huge difference here in the time that you monitor the heart rhythm. So in the case that you detect atrial fibrillation in the STROKESTOP study, you're likely to see that these individuals have a high burden of atrial fibrillation, something that we now believe actually is more important than we thought before.
But is that the end of implantable loop recorders then? For that indication, at least?
They did actually have quite, I think, quite an interesting and large reduction in ischemic stroke rates in the LOOP study. So one could also perhaps think about, they aimed for a very, very large risk reduction in their power calculation, and perhaps that was something that one could have amended. So perhaps, well, one doesn't know, but it might be that the study was slightly underpowered to show its endpoint, but that's of course speculation.
I don't know how it is in Sweden and Germany. The loop recorders are not very easily reimbursed, so that's actually why the insurance companies kind of killed it early, and they're not implanted very widely. Still, we have the opportunity more and more in our cardiac patients with devices implanted to look at the ICD and CRT and pacemaker memories. and obviously work with the same issue. So we have the atrial high rate episodes, which are defined as a period of longer than 6 minutes. And I tend to give anticoagulation therapy there if I have a reasonable intracardiac electrogram. Is that actually a good idea, or would you believe that we need longer periods, which you can only detect, or most likely detect, if in a situation like in STROKESTOP?
Well, of course, we will know more once we have the studies looking at this. The Artesia and the NOAA AFNET study are addressing these issues. But I think if we look at the per protocol analysis in loop, we can see that those that actually had a loop recorder implanted and had longer episodes, more than 6 minutes, recorded on the loop recorders, that they had a significant reduction in the stroke rates, and they did not have a signal towards increased bleeding. So I would at least say, if it's not efficient, then at least looks safe. So I would probably continue. I do the same as you do in my clinic, and I will probably continue at least until I get the results from those ongoing studies.
I'm always wondering about those cutoff values for minutes of AFib. And I think in the loop study, there was cut point of 6 minutes. And I think it's a little bit different in your trial. Not really being into an electrophysiologist or not being really into AFib, can you tell us a little bit about your thoughts about those cut points? Is that really important?
I think all cutoff values for atrial fibrillation are quite difficult, to be honest. Even the 30-second ones that we read about in the guidelines, that you should have 30 seconds of atrial fibrillation in order to diagnose atrial fibrillation, there is actually no sound science behind that cutoff. That is something we have used in trials, but we actually looked at very brief episodes of atrial fibrillation-like activity as well in our recordings for patients in the STROKESTOP 1 and the STROKESTOP 2 studies. And we termed those micro AF patients, and we could see that they developed clinical atrial fibrillation to a great extent in a few years' time. So I think this is probably a continuum of a disease. So, but we do this all the time in medicine, don't we? I mean, hypertension, we set a cutoff for that, atrial fibrillation. So it's to simplify basically a continuous disease, I think. And
getting back to risk reduction, I think comparing both studies, LOOP and STROKESTOP, the population exhibited, I think, really maybe quite the same CHA2DS2-VASc score, 3 point something in your trial, and I think it was 4.0 in the LOOP study. I'm wondering, could you speculate on the difference of the results of the outcome in terms of risk? I think population is really the same, but is it just the huge population, the larger number of patients in your study?
Well, the larger number of patients, we also did have different outcomes. So in the LOOP study, they chose to have an outcome of stroke and systemic embolism combined, and we actually had that and added all-cause mortality. And mortality was actually a major driver of events in our study. So had they included mortality, perhaps their data would have looked different as well. Both groups are high risk, as you point out, high risk of stroke. So CHA2DS2-VASc of 3.5 or 4, I don't think that is such a great difference. So I think that both groups are really high risk in these studies. If you compare to, for example, consumer-based screening studies, where the risks are very much lower, of course.
But that's highly interesting. What's your speculation on that? What is the meaning of atrial fibrillation in stroke anyway? I mean, this goes a little further, but we've seen the discussion in the device studies where we see strokes occurring before the recorded episode of AF or not in direct timely proximity. So is it that AF is a marker, or is it the immediate cause of AF? And as you alluded to, we see an increase in mortality that might or might not have to do with the rhythm disorder. What's your thought about that, and what does that mean for our screening approaches?
Well, I think patients rarely have just atrial fibrillation, right? For most of us, when we detect atrial fibrillation, it's kind of a wake-up call. This patient is likely having other cardiovascular risk factors, hypertension, obesity, sleep apnea, etc., etc. So I think it's both a marker of other cardiovascular disease, but in itself, it also carries a risk for stroke. So I think it's hard to separate the two, actually.
And now going back to the very means of using, you use the thumb ECG, so sort of external event recorder. Is that something, I know it's from a Swedish company, by the way, I use it here in my practice as well, but is that something that is actually used in practice in everyday clinic? Is it reimbursed? Because in Germany, used most of the time when we suppose somebody might have AFib because of extrasystoles, because of a large atrium, because of HFpEF or a stroke even in the past. We use just regular 24-hour Holter ECGs. We might use them for a longer period of time. So you already said how many minutes only is 14 minutes in total recording time. I mean, is there any way to calculate that a 24-hour, 72-hour, 1 week Holter might be superior to that? And then what do you think? What is the best and practical approach?
Well, first of all, in Sweden, it is reimbursed, and it is used in the clinic as well. But not only thumb ECG as we used, but various other ECG methods as well. So the MyDiagnostic, for example, or and well, there has been some studies comparing prolonged ECG, continuous ECG recordings, and intermittent ECG recordings. And we did one study when we compared 14 days of continuous ECG recordings with intermittent ECG recordings. And obviously, you will detect more atrial fibrillation if you use a continuous recording for 14 days. On the other hand, in the study we did, the patients experienced quite a lot of discomfort when using the continuous ECG recording. So there's always a balance, of course. The more you monitor, the more you'll detect. I believe that quite firmly. But approximately, I would say, I think there was one study, approximately 5 days of continuous monitoring would equal 2 weeks intermittent ECG recordings.
To detect AF, but that doesn't necessarily mean to reduce stroke.
Indeed. So that hasn't been studied.
And with regard to this last point, for our viewers, one might argue that, as you pointed out, the more you measure, the more you screen, maybe the more dangerous it gets for the patient, because deliberately induced anticoagulation and maybe bleeding risk. And could you just, for our viewers, tell us something about risk in your study? We get you right that risk is, this strategy is safe, screen and then put patients on anticoagulation, is that right?
Yes, well, indeed, we were quite concerned if we would detect atrial fibrillations through screening and initiate oral anticoagulants. And mind you, when we started the study, there was only really vitamin K antagonists and one NOAC on the market. So there was a higher bleeding risk initially, of course, using vitamin K antagonists. So we were quite concerned about this, and this is why we included it in our outcomes. Actually, what we see is that we have a lower risk of bleeding in the group that participated in our screening program. And that's kind of surprising at first, but then we thought, well, the individuals in whom we detect atrial fibrillation, they will be sent to a cardiologist for follow-up. And in doing so, You will also, of course, take the blood pressure if you initiate oral anticoagulants. You'll do a checkup of renal function, for example, many things that are known to cause bleeding. So we actually detected less bleeding. So we found it quite safe, to answer your question there. But of course, there's always other, side effects of screening. So you can cause worry amongst your patients, which we didn't measure. So perhaps monitoring your heart rhythm can cause increased anxiousness that you're going to have a heart condition, or perhaps you can feel falsely reassured that you did this monitoring for 2 weeks and not seek healthcare for an arrhythmia afterwards. So there are always side effects of screening that we need to consider, but we didn't look at that really in STROKESTOP.
So when you designed your study, there were no Apple Watches or something of that kind. And if you would have the same possibility now to redesign such a study with all the novel devices, would you in some way change the strategy for screening? Or do you believe that as more and more people are coming to you and to other cardiologists with some findings from, again, Apple Watches or some other devices, that the strategies will anyway change in the next years?
Well, probably the strategies will change, but one thing we saw was that participation in individuals who actually had poor health and poor socioeconomic conditions, which was much lower. And we know that these individuals are actually the ones more likely to have the disease. So I think this is a major area of focusing on. And I think perhaps one could reach out to these using simpler means like ECG patches sent to them by mail, for example, that they don't have to go to a screening center as they had to in our study. Perhaps in the future, more other digital devices such as watches, for example, might be available. But at least in Sweden, mainly those that own these devices currently are of higher socioeconomic standing and are younger, more commonly male. So we see more watches and device-detected arrhythmias in those at lower risk currently.
Probably comparable to Germany, I think. Will we be needing a cardiologist at all, say 10 years from now, if with what device soever people can measure their own heart rhythm, they get an algorithm from the internet? I mean, that's also an issue with the watches. The algorithm is pretty good, and it tells you AF or no AF, and only something in between, ventricular ectopic beats, or so they don't recognize so well. But that goes far towards artificial intelligence, I guess. And couldn't the GP then say, okay, well, I initiate anticoagulation, and wouldn't that be dangerous also?
Well, I agree with you. I mean, the positive predictive values that we saw coming out of the Fitbit study now was really good, 98%, I think, in the secondary outcomes. So very, very high accuracy. But I don't think that we should think that they don't need a cardiologist. I think atrial fibrillation is complex as a disease. So it's not only about anticoagulation, actually. It's also about rhythm control, of course, and it's about all the comorbidities. So I think it is quite a complex disease, to be honest. So it's not so simple as just to initiate oral anticoagulants, I think.
Do you think there's certain kind of educational bias? From my experience, if I close a PFO, I always tell people, well, do you have an Apple Watch? Well, yes, okay, you have one. Those between 35 or 50 with an Apple Watch, they always have AF and consecutively. You discussed that in the paper. Could you comment on that?
Well, I think you are right. There will be a bias in any study you do. But if you think about, I think in the STROKESTOP, we try to minimize at least bias in the control group, which is quite difficult to do, to be honest. So what we did was that we randomized everyone, and those who were in our control group were not aware of the study going on. So if you compare that, for example, to the LOOP study, where everyone was invited first to a screening visit, given information, given consent to have an ILR in case of randomization, and then being randomized. I think that caused a lot of concern in the control group, and that they probably seeked a lot of healthcare as compared to the STROKESTOP, where the control group, except that awareness became more and more frequent of AF in the society, but they don't think they behave much different being in the control group.
We discussed a lot, and we were rather critical already and compared the different studies, but taking it back from where you started, that you did a very pragmatic approach in an actually easy study with a positive finding and a reduced endpoint. Is that guideline relevant? I mean, wouldn't we have to use these devices and this kind of approach? I mean, this is where we are now. We're discussing about the future, but today we have this study. Don't we need to invite everybody now, age 75 and 76 and older, to use this kind of device and reduce stroke?
Well, we did actually look at the health economy of this, because it sounds quite expensive, doesn't it, to invite everyone in the society to do this ECG monitoring, to follow up with a cardiologist. But actually we could see quite big cost savings in doing screening. So of course that's something for the guidelines to look at once that's published. But I do think that screening is at least feasible, cost effective, and we can see a reduction in hard clinical outcomes. So I think many individuals aged 75 and 76 would like to be screened for that reason.
So if you start screening at age of 75, then surely comes the question, would you redo the screening at age of, say, 80 or 85? Surely nobody knows. But this is, I think, the next question behind this, if we start screening at that age. But I have some very pragmatic question, being a non-cardiologist. So if a GP asks you, beginning of 2022, who's in care of a 75-year-old patient who has no access to any of these model devices, how often should we recommend our GPs to do screening for atrial fibrillation in general care? And should we do that just by clinical examination or by routine ECG? Any suggestions for the GP?
Well, if we're talking about inviting sort of individuals to doing a single time point ECG or a pulse palpation, that is recommended in the ESC guidelines, of course. But larger recent studies in the US, such as the VITAL AF study and also the D2 AF study performed in Europe, it doesn't actually show an increased detection of atrial fibrillation if you do a single time point ECG. So I think it depends quite much on your population. So if you have a population that is seeing a doctor regularly, I think most individuals with persistent or permanent atrial fibrillation will have been detected. So you will not detect that much with just a single time point screening initiative. So I think it is this more systematic or prolonged approach that will detect more atrial fibrillation. We only detected 0.5% new atrial fibrillation with our single lead device.
So adding to that, I'm not sure from your paper, maybe I didn't read it or it wasn't in there. Did you, when it's supposed to do an ECG, a single lead ECG twice a day, and has it always been twice a day, or have people with palpitations, just feeling of heart rhythm disorders, actually recorded more than that? And would the recording or the chance, the positive finding, be higher in those being symptomatic? Or is it always just twice per day, 14 days?
They were asked to do twice per day. But some individuals just really enjoyed having the device at home and did a lot of more registrations. But most just did twice per day. So there was no extra instruction to do in case of symptoms in the STROKESTOP study. So we don't have any good data on that.
Right.
So thanks a lot. We had very, very many questions actually to you. So we are very happy to have met you, and we recommend our colleagues to really read the paper because it's so important for clinical practice. Thanks, Emma, for really initiating, doing, and reporting this important trial. And we are definitely looking forward to reading more from you in the next years. So have a nice evening in Sweden. Thanks a lot.
Thank you very much for having me.